right, good morning, everybody. I guess we'll get started because it's 9:30. I'm Rob Ehrman from Wayne State. This is Joe Miller from Henry Ford. Thanks for coming to the most exciting didactic at all of SAEM.
I know.
Yeah.
Woo! Yeah.
Right. So these are our sort of like overarching highbrow objectives. They're available. The slides were distributed online, so you can look through them in more detail. But really, our goal in this sort of short time that we have you is to sort of describe some of the basics of missing data and really try to hammer home like why it's important, how it can change dramatically sort of the results and how you interpret and imply them. So you're already interested in missing data, you've come here. So the way we're going to do it is I created a simulated data set for a sepsis trial and with different patterns of missingness. So I'm going to go over some of that at first, and then Joe's going to talk to you about different patterns of missingness, and I'm going to bring it back and show you how the different patterns lead to different results. And so just as a disclaimer, the goal of this is to be illustrative, so I didn't always use sort of the best statistical practices, so don't hold my feet to the fire too much. So in terms of the simulated data set, we know that it's hard to identify patients who have sepsis in the emergency department, especially at the lower end of the severity spectrum. Patients that come in shock, we already know, that they're sick. And SOFA score exists, but there's too many variables, and QSOFA is probably not enough variables. So ultimately, you want something that's easy, it's got commonly available data points, and you want it to perform well in less severely ill patients. And so for this simulated model, our outcome is going to be in-hospital death. Our predictors are age, lactate, and shock index. And for reasons that don't really matter, you think that LV ejection fraction at presentation is going to be predictive. So we've got 343 patients. We have all of the predictors of interest, and then we have all the other usual things, vital signs, labs, et cetera. We're going to model our outcome with logistic regression. This is our model here. And our predictor of interest, like I said, was LVEF, but we're modeling it here with an interaction with shock index. So what we're trying to see is, does the effect of EF on the odds of death vary by levels of the shock index? So we enter all our data and we run an analysis, and this is the outcomes that we get. And so what you can see, oh no.
There you go.
Yeah, I thought that was a laser pointer, but I guess not. So what you can see here is that, so remember, this is our predictor of interest. This interaction term is significant in the model, and then these are all the parameter estimates. So the odds of a 5% increase in EF on the odds of death at different levels of the shock index. Remember, lower levels are normal, so a shock index goes up. It shows that your vital signs are more deranged. And so our model actually looks like it's performing pretty well. Our model discrimination area under the curve is 0.86. So what that's telling you is how well the model discriminates between patients that have an event and a non-event and don't have an event. And then finally, this last graph over here is something called the calibration curve. You may not have heard about this or seen them. They're not reported often enough. But essentially, another thing that we're interested in with model results is how well does the predicted probability of an event match the observed probability? And that's what calibration is telling you. There's a number of different ways to assess it, but maybe the easiest is just visually to look at this graph. And so a well-calibrated model will fit this gray line, which essentially is saying that the observed and predicted probabilities are the same. And you can actually see in this simulation that the model is pretty well calibrated. So knowing nothing else, just kind of a quick show of hands or think in your brain, like, does this seem reasonable? Based on these results, you'd say, yeah, we should all be doing LV ejection fraction. Okay, so remember that, and we're going to come back to it at the end, and I'm going to turn it over to Joe.
All right. Thanks, Rob. This is rapid fire here, so we're going to quickly talk. I'm actually going to skip over this one. We're going to quickly talk about kind of 3 ways to view missing data in general. And you've probably seen this before. You've read method sections that describe some of this. But we'll categorize missing data into 3 ways. One is missing completely at random. So this means that the probability of that data missing, whether it's an outcome or it's the variable of interest, is completely unrelated to anything observed or unobserved about the patients in your data. So one example might be, you're collecting biomarkers as an outcome for patients in a study, and one of your research coordinators slips on a banana while going to spin the blood, and the blood spills on the floor. That's completely at random. Similar thing, maybe you've sent surveys out in the mail, and the U.S. Post Office lost 3 of the surveys you sent. So these are completely random events. The beauty of missing completely at random is if it's present, you can analyze a complete data set. You can analyze the data set that has complete data without having bias. However, it's rarely plausible in medical in clinical studies that things are missing completely at random. So often we can't use this to analyze our data. We can't assume that our data is missing completely at random. Most common is missing at random. This is when missing values are dependent on observed values you have. So one example may be patients that had higher amount of adverse events early in a trial don't show up for their outcome assessment or stop taking the medication, and you lose touch with them. And so the reason you have missing data on their outcome is directly related to the fact that they had adverse events early in the trial, for instance. There's not really a good way to prove that data is missing at random, but as Rob and us will show, there are ways to adjust your data to essentially impute data regarding missing at random. And the last is missing not at random, and these are tough because often you don't have factors available to you that can explain why that data is missing. One example might be patients aren't reporting drug use patterns because they fear repercussion, but you have no data within your data set that would even hint to that. So sometimes missing not at random, you just have to put on your thinking cap and think, could there be a bias introduced based on how I collected the data? And I think this is, every statistician will harp on this, and I'm sure you've worked with statisticians that have said this as well, that ultimately preventing missing data is the best thing you can do by far. It's still you can put lipstick on a pig, but if you have too much missing data, missing at random or missing not at random, you're still going to have problems with your results. And you're going to lose statistical power in whatever analysis you're going to do. So how do you deal with this? So I mentioned you can do a complete case analysis. This means that you just drop patients that you're missing. Let's say you're missing the outcome for death in the case of Rob's data. You could just drop all those patients and just run analysis on the rest of the patients. And that would, if it's truly missing completely at random, you don't introduce bias into that analysis. However, if it's missing at random, meaning there's factors that influence the missing data, you will introduce bias if you do complete case analysis. And then there's also things like last observation carried forward, where say you're doing repeated measures of maybe blood pressure or BMI or something in a study. You could carry forward the last observation to fill in missing data points on those repeated measures. You can also fill in data by, for instance, taking the mean of the prior values or the median or whatnot. These aren't quite as strong, though, as the next two ways I'll briefly talk about how to deal with missing data. So one relatively common way is to use maximum likelihood estimation. So this and the next one I'll talk about, which is multiple imputation, are using estimates based on the existing data you have. So taking this fact that there's factors within your data, particularly for missing at random, that are influencing what has missing data elements. These use regression-related calculations to fill in those missing data points based on the factors that are present in your data set. So you end up getting unbiased parameter estimates, and you also create errors around what those parameter estimates are. So most current statistical programs will have programs within it to do this kind of estimates, and something that you can certainly ask your statistician to do for you to impute or to fill in missing data. The most common one you often see in the literature is multiple imputation. And so this is a reasonable way to deal with missing at random, missing completely at random data. And what this does is you also use typically regression techniques to create multiple data sets. Often people will say imputed 10 data sets, and then take that. Those data sets will reflect the uncertainty of what the true value would have been in that missing data point. And so it also acknowledges kind of the uncertainty and variance that could be present when you have missing data, but it will give you an estimate of what that missing data was so that you can run a final less biased calculation than if you had completely ignored that missing data.
And one of the strengths of multiple imputation, just to add, is that you have a bunch of sort of covariates that it pulls information about the missing data and the relationship to other covariates that you specify, and so that's how it creates a range of values, and then you get very robust standard errors for that parameter estimates that you impute. And so, okay, so going back to our simulated data set, remember this is what I presented to you initially, and it makes EF look super important. And in fact, this was actually generated with 20% of the data missing completely at random. So I created like a deletion algorithm that went through and just deleted data points at random, and I ran it several times until I got something that actually made the parameter of interest, which is this EF shock index interaction term, look really good. And so, this is it's illustrative of the fact that, the first couple I ran actually looked terrible. And so if you just kind of keep going, eventually you get to something that looks good. And you don't really, it's important because you don't actually know which one of those iterations your data set may represent. Now, again, depending on, that's why I say this is not best statistical practices, because this is sort of engineered. But again, you don't actually know what the truth is. So missing completely at random can be bias free, but it also may not be, depending on what data points are missing. So this is a data set I generated, missing not at random, only 10% of the data this time. And so what I did was I went in and I found the 10% pairs that had the greatest lactate heart rate pair, so high lactate, high heart rate, and I just went in and I deleted those. And so what you can see is that now this term of interest is not significant anymore. The parameter estimates still show the same kind of trend of being useful but not changing effect size, but most of them cross an odds ratio of 1, which suggests that it's actually not useful. But the model still has pretty good discrimination. An area under the curve of 0.8, especially if you're talking about sepsis, would be astronomically high, I think. And again, I put this in to illustrate that when you're looking at any kind of statistical analysis, particularly regression analyses, that looking at a single parameter that's output from the model can be misleading or doesn't really tell the whole story. And then finally, this is the full data set. And so again, this is what I set up the simulation to run, essentially saying that this was not going to be useful. So again, most of the parameter estimates for these different strata of, get my fat fingers off the keyboard. Most of the parameter estimates are not statistically significant. The area under the curve is substantially lower at about 70%. So again, each one of these data sets tells like a pretty different story. And so you can see now that, presenting the first one and the second one and the third one, which is sort of truth, would lead you to generate pretty markedly different conclusions. And then finally, this is just another example to illustrate the importance of calibration. This one, I went in and did some targeted deletions across quartiles of ejection fraction, and I sort of alternated between dead and not dead to illustrate how important calibration can be, because you see, again, the interaction term is statistically significant. Our odds ratios all look pretty good. Our area under the curve also looks pretty fantastic. But if you look at the calibration curve, this is crazy. What this is telling you is that the observed and predicted probabilities are markedly divergent. Sometimes the model is overestimating risk. Sometimes the model is underestimating risk, and it varies widely across the predicted probability range. So this model is, not quite useless, but you don't actually know, like in reality, this wouldn't be useful clinically because, no one's going to look at a curve like this and say, okay, well, when you're down here, you're risk is over predicted, and when you're over here, your risk is under predicted. So again, this is a reason that calibration should be reported. It's often not. It's sort of a pet peeve of mine. But anyways, so overall, as I said, kind of the main points are to understand that there's these different patterns of missingness, and they can have pretty markedly, they can have a wide range of effects on your results and how you interpret and apply them. Unfortunately, it's pretty unpredictable. It would be nice if you could say, okay, well, if you have 10% data that's missing completely at random, then you're safe. And if you have 5% that's missing not at random, then your bias or your effect on your results will be X. But in fact, it's unpredictable. There's no way to actually know how that's going to happen. There's also no statistical test to say, okay, is my data missing at random or missing completely at random? You have to sort of make some assumptions about that. It's really critical to understand that these patterns exist in terms of how you apply data and how you do your own analyses. Like what Joe was saying, you wind up with a loss of power, and essentially it's a loss of patients from your study. So for example, if you have 100 patients in your study and you're missing outcome data on 10, that's easy to understand. You no longer have 100 patients, you have 90 patients. But if you have 100 patients in your study and you're missing 2, 3, 4, 5% on some of your covariates, for example, in a regression model, it has the same effect. You now no longer have 100 patients. You may have lost another 15 patients because you have missing data points because those patients don't go into the model. And so that's why it's so important to present your missing data, in your manuscript. That's why you should look for that's why you should look for reporting of missing data, because that helps you, get an understanding of the results. As Joe said, again, the best way to avoid missing data is in the planning phase, the design phase, or involving a statistician early. You want to have a feasible data collection plan. You're not going to get Q1 hour troponins. You're probably not going to get Q 15-minute vital sign checks. So making sure that, again, you have the resources to collect the data the way that you want it collected. Having a good conceptual model as you design and implement your study is also critical, so that you can figure out what the most important data points are and make sure that you focus your efforts on collecting that data. And obviously, consult a statistician early. There's actually a fairly substantial body of literature about missing data. Mostly it's in clinical trials, although a lot of this stuff is actually applicable to observational studies as well. And so as we kind of wrap up, hopefully you understand how much of a problem missing data can be. Remember that it's best addressed at the planning stage when you're doing your own trials, but when you're reading studies and thinking about how you're going to understand, implement those results as it apply to your patients. Studies that don't report missing data, doesn't mean they're wrong, but it also should sort of be a little warning light in your head. There are a number of different ways to address missing data, and people talk about it being fixable or not much of a problem. That's sort of true, but a fully present data set is always going to be more robust than a data set that's been imputed or corrected somehow statistically. And then the most important, also another thing to remember is just that missing data happens. It's okay, we understand it, but like honest and open reporting is really the key. So this is a QR code that will take you to a Google form to evaluate our presentation and tell us what you think, but we can also take some questions now.
Can you go back to your last stage 3 graph or results 3? So the calibration. So you're right, we don't usually see this. Is this the only way to present it? Graphically, or
No, there are other ways. There are different test statistics. This is like a simplified way, and there's actually, like everything else in statistics, there are more facets to calibration than just the calibration slope. So there are some numerical ways to look at it. I can send you some references if you're interested.
graphically or image there.
Yeah.
A lot. I mean, besides being so used to seeing ROC curves,
Right, right. Yeah, I mean, there's probably not enough like data visualization in papers because even though it's to some extent the best way to understand like, the overall trend of things, but yeah.
Right.
Other questions?
I guess one thing, just to bring up one related thing is, I've noticed working with statisticians at my place, they often will default to doing a complete case analysis and not ask about imputing. So I think it's something I always have to check with them up front. I'm like, how, really explicitly say, how are we going to deal with missing data? Otherwise, I see, wait, what happened to my sample size? It got cut in half because they did a complete case analysis.
Yeah, and it's not addressed as often as you really think it should. I mean, hopefully you'll have sat in here and you'll go like read some papers and you'll be like, well, how can this not be addressed? But it's a problem, so you'll all be better prepared.
Is there some rule of thumb limit where you say, I'm sorry, this is too much missing data, we can't use this?
I think it probably depends on who you ask. Like different numbers are out there. I've heard 30% is a number that's often quoted for multiple imputation because it uses something called Markov chains, and when you have too much missing data, the algorithms oftentimes don't converge. Sometimes they do, but it's just felt to be like way too biased. And there's like some plots that you can look at and they're just all over the place. But that's what I mean. The less missing data, the better. But 30% is an often quoted number.
Yeah.
What's that? Well, any degree of, 30% of, not necessarily at random. That's one of the, you make the assumptions, if you're doing multiple imputation, for example, the assumption is that your data is missing at random because you are using patients that have complete data. So say your data point of interest is major adverse cardiac events, and you have, that's not a good example, but just stick with it. So you're missing, 30-day MACE, and that's one of the data points you're interested in. And so that may be related to age, it may be related to gender, it may be related to smoking status and, troponin. So the multiple imputation works by looking at patients that have all of that data available to kind of figure out what the distribution of having a major adverse event is. And that it uses, again, the data points that exist to impute the missing ones. And then you were making that assumption that it's missing at random because you need that assumption to say that, okay, all these other variables influence whether or not you had a major adverse event or not. And that's why I said there's no statistical way to check whether that assumption is actually true. There's some ways you can actually, most of the time what people do is they will go in and create a data set missing not at random as a sensitivity analysis and see if it substantially changes the model outputs. But that's generally the way it works.
And just from a mechanistic standpoint, multiple imputation is something that is just part of a statistical program. You're not asking somebody to do it for themselves. You can't have a manual program computer.
I suppose you could do it manually, but yeah, it's usually part of a statistical package that the statisticians are using. It does add a substantial amount of time to complete the analysis, but it's not manual by any means.
But you'd still want to see a calibration of that amount that you have done imputation.
Yeah. Short answer is yes. It becomes a little bit more complex about what you do with multiple imputation and you pool all the data. But the short answer is yes, there are still ways that you should be checking and reporting that. Sure.
Should we be using more than one method to deal with missing data and kind of comparing the results, or should we just pick one and go with it and say, this is where we're hanging our hat?
I think I would say in general, you can go with some of the likelihood estimates or multiple imputation are both excellent ways and probably usually will be the most accepted. So I don't think you necessarily have to test multiple ways if you want to be extremely thorough, you can as sensitivity analysis, but I don't think most journals will fault you for picking one and sticking with it.
I think maximum likelihood estimation is a little bit less computationally intensive. And some of it is actually, some statistical programs actually automatically have that done on data sets, like it runs in the background, whereas multiple imputation requires some more coding. But I think I agree with Joe. It's like you kind of pick what you want, and you'll always find someone that says you did this wrong, and no matter what you choose. So it's like a matter of opinion.
Of course, one thing to be wary of is with multiple imputation, if you do the same multiple imputation several times on the same data set, you're going to get slightly different results every time. Great. Well, I think the next group is coming in. So thank you for attending, everyone.
Yeah. Thank you, guys.